leg pain, mostly in the right. Can you tell me a bit about that?
Yeah, so I've been training for a marathon, which is in 2 months from now, and I've started getting pain in my two legs, two front legs, I should say, mostly in my right. And yeah, I think I have shin splints, maybe.
Okay. Can you point to exactly where the pain is?
Yeah, it's just kind of this area.
Okay. Does it radiate anywhere or further up and down?
Maybe just to my big toe when it gets aggravated.
Okay. Okay. And how long does the pain last for when you experience it?
Well, it usually starts about 5 minutes into my run, and then it lasts the entire time, and then maybe 20 minutes after I've stopped running, it subsides.
Okay. Do you experience it at any other time? Because I see that you are a retail manager.
Yeah, if I'm doing too much running around with a customer, then maybe halfway through my shift, it starts like flaring up again.
Okay. All right. Would you rate your pain out of a scale of 10?
Well, right now I don't feel anything.
Okay.
If I'm walking a lot, like at work, then maybe a 3 out of 10.
Okay.
And when I'm running, 8 out of 10.
So very high. Okay. Can you describe what the pain feels like?
Kind of like a dull, achy, and then it just feels really tight.
Okay. Is anything aggravating it, or is it just the running and walking?
Just, yeah, running and walking a lot.
Are you doing anything to help alleviate it afterwards?
Rest works, and I ice it a lot.
Okay. All right. Are you taking any meds for it?
No.
Anything? No. What type of shoes are you running in?
My lucky shoes.
Oh, okay.
I have them if you want to see them.
I would love to see them.
So they're 10 years old maybe.
Yeah.
They have no soles left in them.
Okay. So not really a whole lot of support.
Oh, I didn't know that it would even be a factor.
Yes. Yeah. Typically you want to get new shoes every 6 months, especially if you're training in them. So that's probably an underlying cause for what's going on right here. So I'd like to do an assessment to see what's going on.
An outcome measure is the result of a test that is used to objectively determine the baseline function of a client at the beginning of treatment. Once treatment has commenced, the same instrument can be used to determine progress and treatment efficiency.
During the observation phase, a postural assessment is conducted to gain information on any abnormalities or functional deficits during a normal standing posture. The therapist will look to see that the client's muscles are balanced. The pelvis is in a neutral position. The anterior superior iliac spine is directly above the pubic tubercle. The client's earlobes are directly above the shoulders, and that there is a natural curvature in the spine.
Having the foot land directly under your center of gravity minimizes stress on the hamstrings and the knee. A lengthy stride will cause the hip stabilizers to work harder. An efficient arm swing can make for an efficient stride. Elbow flexion should be somewhere between 60 to 90 degrees, meaning the forearm should be pointed slightly downwards towards the ground. Pronation should be 5 to 10 degrees as it strikes the ground. Slight pronation is the ankle's way of dispersing impact. Look for knee rotation inwards, Achilles tendon and calcaneus alignment. Asymmetry between sides is considered abnormal. The leg should have a slight bend at the knee. The leg muscles should engage before your foot hits the ground, ready to absorb that impact. This minimizes the stress on the knee, warding off runner's knee and other issues. Having your hips level as you run is key to preventing irritation along your IT band.
A consent to assess is completed to ensure that the client is made aware of the reason for the assessment and has verbally given their consent. The registered massage therapist informs the client what will be occurring during the assessment and the areas of the body involved. The client is made aware of any cautions or contraindications, if applicable, and the overall benefit to having the assessment completed. Ramifications of not having the treatment and an opportunity for questions they feel is necessary is provided. The client is notified that they can stop or modify the assessment at any time allowing them to feel in control and comfortable during the process.
Palpation of the affected compartment may reveal tightness and occasionally defects in the fascia from continued pressure. Look for contraindications of the acute phase such as hard, taut, shiny skin, client complaint of severe unremitting pain, or absence of the dorsalis pedis pulse. The client should be referred to medical attention immediately.
Okay, Kelly, so I'd like to take you through the ranges of motion of the ankle. We'll start with active, so you can just mimic my movements.
Okay.
So we'll start with some dorsiflexions, so bring your toes towards your knee.
Ooh, that hurts a little
A
bit.
little bit of pain?
Yeah.
What would you rate your pain?
Oh gosh, maybe like a 6 out of
6?
10 on that.
Okay.
Yeah.
And then if we can plantar flex, put your toes towards the floor.
Okay.
Okay. And then we're going to invert, so kind of face your bottom of your foot towards the wall.
Okay.
Okay. And eversion, so your bottom of your foot towards the opposite wall. Okay. Okay. No pain with any of those?
Nope.
Okay, so I do see that based on how you're sitting, your feet are in plantar flexion. So what that tells me is that your gastrocs and your soleus are probably a little tight.
Oh.
Okay, Kelly, so we're going to measure the different ranges of motion, and we'll start with dorsiflexion again. Okay, so bring your toes to the ceiling as much as you can.
I think that's it.
That's about it?
Yeah.
Okay. That's about 15 degrees, so that's under normal. Normal is about 20.
Okay.
Okay, and then bring your toes towards the floor. Okay, so about 45, that's about normal.
Okay.
And, okay, so bring the bottom of your foot towards the wall. Okay, about 30, that's normal. And again to the opposite wall. And about 25, that's also normal. Okay, so Kelly, I'm going to take you through the passive range of motion. So I'm just going to stabilize your tibia, put my foot underneath, and I'm going to passively dorsiflex. Let me know if you experience any pain or discomfort.
Nope.
Nothing? Okay. And then we're going to plantar flex. No. You have pain with that?
A little bit.
A little bit of pain?
Yeah.
Okay. And then we're going to evert your foot. Any pain with that?
No, it's fine.
It's fine. And I'm going to switch arms. Any pain with that?
No.
No? Okay. Okay, Kelly, so now we're going to do resisted range of motion. I'm going to apply resistance, and you're going to build the resistance for 5 seconds and then hold for 5 seconds.
Okay.
We're going to start with inversion, then eversion, plantar flexion, and do dorsiflexion last because I know it caused you pain with active range of motion.
Okay.
Okay. All right, so build. 1, 2, 3, 4, 5. Hold. 5, 4, 3, 2, 1. Good, you get a 5. Was there any pain with that?
Nope.
Okay. Ready, go. 1, 2, 3, 4, 5. Hold. 5, 4, 3, 2, 1. Good, get a 5. Was there any pain with that? Nope. Okay, and then plantar flexion. Push against my arm. Ready, go ahead. 1, 2, 3, 4, 5. 5, 4, 3, 2, 1. Good, you get a 5. Was there any pain with that?
No.
Okay. And now dorsiflexion. Ready, go. 1, 2, 3,
Ow,
4,
that
5.
hurts a little bit.
Do we want to stop?
Yeah, I think so.
Okay, so we'll consider that an empty end feel. Okay, Kelly, so we're just going to rule out any muscles that may cross over the knee that would cause issues. So if you were to extend, do you have any pain? Nope. Nope. range. And then with your toes, can you extend your toes upwards? Yep. Okay. Okay. And can you abduct? So separate your toes. Any pain? No. Perfect. Okay.
Holman sign tests for deep vein thrombosis. Put your client in supine with the knee extended. Passively dorsiflex the client's foot. Positive signs are deep pain in the calf during dorsiflexion, tenderness with palpation on the calf, swelling in the leg, or loss of the dorsal pedis pulse. The bump test tests for tibial stress fractures. Have the client lie supine with the knee extended. Slightly tap the dorsal aspect of the foot. A positive sign is pain that radiates at the stress fracture site.
Okay, Kelly, so now that we've gone through all the ranges of motion, I'm thinking that your gastrocs and your soleus are actually quite tight, so I'd like to take you through some muscle length testing.
Okay.
So to start with gastrocs, your leg's already in extension, so they'll be a little taut right now.
Okay.
What I'm going to do is I'm just going to try and dorsiflex, which I know causes you a bit of pain.
A little bit, yeah.
So there's not much range, about 10 degrees, and it's kind of a hard, slightly springy end feel.
Okay.
So now I'm going to see about soleus. I'm just going to put this towel underneath just to release the tension on the gastrocs.
Okay.
And again, try and dorsiflex, not getting a whole lot there. So what that's telling me is that your gastrocs and your soleus are tight.
Okay.
A consent to treat is completed to inform the client what will be taking place during the massage and to receive verbal consent in order to proceed with the treatment. The client is made aware of the benefits and cautions or contraindications and understands any risks or any possible side effects. They are informed of other healthcare possibilities if necessary and understand that they can stop or modify the treatment at any time, ensuring they are comfortable. If treatment of sensitive areas is clinically indicated, the therapist is to obtain verbal and written consent for treatment of the sensitive areas.
Positioning is with the client lying prone to reach the compensatory structures. Pillows are placed under the abdomen and ankles. The hydrotherapy application is deep, moist heat before stretching the fascia of the gastrocnemius and soleus. Fascial techniques, massage, and passive stretch are used to elongate the shortened, thickened fascia, starting with the antagonist. Fascial techniques to treat the shortened gastrocnemius and soleus include skin rolling and fingertip spreading. Myofascial release along the affected muscles with combined passive motion is also used. The soleus is treated with longitudinal connective tissue cutting techniques while the therapist dorsiflexes the ankle. The client is turned supine. The anterior thigh is treated with Swedish techniques. Trigger points that refer into the anterior leg are addressed. These include adductor longus and brevis. Longitudinal fascial techniques such as connective tissue cutting are applied to the borders of the anterior compartment to loosen the fascia and to reduce the compression. Short diagonal strokes are used from the borders to the middle of the compartment to further loosen the fascia. These can be combined with a passive stretch into plantar flexion. Cross-fiber frictions are applied to adhesions within the tibialis anterior. These are followed by an application of ice and a stretch.
Okay, Kelly. I'm going to suggest that you come to me once a week for about 60 minutes for the next 2 months to get you ready for your marathon.
Okay.
I'm also going to give you some home care recommendations. So I'd like to tell you to take a week off from your vigorous training just for now, and then kind of slowly ease into training like twice a week or 3 times a week kind of thing.
Okay.
I'm going to give you some stretches that you can do before and after your training, just to make sure that your gastrocs and your soleus kind of loosen up, and we don't want to increase the pressure in the compartments of your leg. Okay, Kelly. So to start off, I'm going to show you how that you can lengthen your gastrocs and your soleus. So have you extend your leg, and you're going to dorsiflex, so bring your toes up to the ceiling. Stretch your gastrocs. You can also either hold a wall or a table and do this. For soleus, if you just bend your knee a little, you can feel soleus stretch. And then for tibialis anterior, just plantar flex, so bring your toe down and slightly invert your foot. So I'm also going to show you how you can do a bit of self-massage on your legs. Yeah.
Okay.
So if you can kind of squeeze your gastrocs, okay, going up and down the limb. Okay. You can feel your tibia go to the lateral side, the outer side, and just kind of strip along the bone. And that'll help with your tibialis anterior.
Okay. That's nice.
Yeah. And then I would suggest after you go for your runs to either have like a cold bath or put an ice pack on just for about 10 minutes just on the top lateral side of your leg.
Okay.
And be sure to stretch after.
Okay.
And then I'm also going to suggest, I'm going to refer you to get orthotics so you can get some new shoes.
Okay, I can do that.
Okay.